Okay, so this is chapter 13, and it's broken into anesthetic problems and emergencies. There is a big section in here on CPR. I'm not going to cover that. I know you guys talk about CPR in ClinMed 5. So I'm not doing CPR. I'm just going to talk about some common problems and then some high risk situations, because when you guys get into practice, I've told you that you have your everyday 6-month-old, 6-month-old female golden retriever to be spayed, and she comes in very healthy. And then you got the 13-old Shih Tzu that has 4 teeth and has a raging heart murmur and elevated liver enzymes, so you're going to have patients that run the spectrum. And what I've tried to tell you about anesthesia is that we're trying to teach you to do it safely, but every anesthetic drug in the wrong hands or anesthesia done wrong can result in death. And that's kind of when I talked about alive and dead, and you kind of hover in the middle. That's where you try to keep your patient. So it's all about interpreting the clinical signs and understanding your drugs and procedures so that we try to avoid that. So typical problems fall under one of these categories, human error, an equipment failure of some type, adverse effects of either the procedure or the drugs that you're given. But then, is there an elevated risk in that patient that caused that problem, regardless of drugs and procedures? Like I told you guys, when a 6-month-old bulldog walks in for a spay, automatically they're an elevated risk because of their breed. And so, before even listening to their heart, before looking at their chart, I'm already concerned. I'm already making a plan in my head of how I'm going to anesthetize that dog. And again, there's no such thing as an elective bulldog or a level 1, which we call, normal or elective. They usually carry some type of risk. Now, the human error part is where we have a lot of control, because you can do everything you can, to make sure, right now we're trying to give you training. I'm trying to give you tips, explain scenarios, make sure you understand equipment. But if you're not familiar with the equipment or the agents, you have to understand about the drugs you're giving. That's why I say review the drugs before surgery. Make sure you know how the machine works. One thing, and again, I'm trying to fill you with as much knowledge as possible before we're done. I always told the students that were going on to externship, one of the first things you need to do before you start helping in surgery is find the anesthetic machine and hook it up and play with it before you have to use it on a live patient, because the machines at school have like labels on them, and they're newer machines. And then you might go to your practice and you look at the anesthetic machine and it looks nothing like the one you used in school. And that's extremely common. I think at VCA, we have probably about 15 different anesthetic machines. They all look different, but they all have the same parts. They all function the same way. They deliver oxygen and anesthetic. They relieve exhaled gases. So, but you wouldn't want to go in day one for a surgery and not be familiar with how that machine works. And that's kind of on you. Maybe you go into work a half hour early and play with the machine before you have to help in surgery. And any of you guys for surgery rotation, you can go in the night before and look at those anesthetic machines in surgery. I know Miss Long has showed them to you. Obviously, I posted videos on Moodle of how to trace the flow. But some people went into surgery last term and they're like, oh, nobody ever showed us how to use the machines. Well, A, that was false. B, there was videos online. We were online. I can't have an anesthetic machine at my house, but we made opportunities for machines to be available. So that's not an excuse. You know, at any point you can go in and look at those machines. We also met in person and went through a machine. So the information is there. If you don't get a good history or physical exam, you could miss a murmur. You could miss muffled lung sounds. You know, I think about the big things we need to look at is cardiovascular and respiratory health. Are there any cardiorespiratory diseases, any neurologic deficits, and any concurrent organ disease? You know, because your liver and kidneys metabolize the anesthetics and excrete them. So if an animal has liver or kidney disease, you know, we have to know that ahead of time. This is big: calculation and administration errors, giving something via the wrong route or the wrong amount. You guys in surgery will have your drugs, well, your calculations are usually double checked. Then you will draw up your drugs and someone will check them that you drew up the right amounts, and then you will mix them and give them. So you never mix your drugs, because I had a student bring me a syringe and she was like, can you check my drugs? And they were all mixed in one syringe. And I'm like, how am I supposed to check your drugs? Because they're all mixed together. I don't know if you drew the wrong or the correct amount. I have to look at them individually. So she had to redraw all of the drugs and we had to throw that syringe away. Because I'd like to say you probably did it right, but I have to confirm it. And in practice, whenever you're using sensitive drugs, like, I don't care how old I am or how much experience, when I draw up insulin, I always have someone check me, because you always have a day where you can have a brain fart or you're tired. And I'm not above having someone check me. I don't care. It's not an ego thing. I'm not like, I got all this experience, I don't need you. I want my patient to be safe. Please check my drugs. Because you can definitely kill something with the wrong amount of insulin or the wrong insulin or giving it wrong. So I just want to be 100% correct for my patient. So take the time, look at your drugs, calculate it. Obviously, fatigue, haste. My biggest pet peeve that I've told you guys is when people go too fast or they don't pay attention. There is a time to go fast. If you have a crashing GDV, if you have a crashing hit by car, if you have a cat that's blocked and potassium is spiking, there are times we have to go fast. But I've had people go fast for elective surgeries because, yeah, you got 5 surgeries that day. You just don't want to make an error by going too fast. You don't want to make an error by, you know, and inattention. I've told you guys the key to safe anesthesia is know your patient, know your drugs, pay attention. Know your patient, know your drugs, pay attention. Most animals do not go into spontaneous cardiac arrest. Like, 1 minute they were 100% normal, the next minute they were 100% dead. I mean, in all my years, I had one animal that crashed right after propofol, like heart stopped. And it was on induction, and the dog had several problems. Radiation, and I had already anesthetized this dog 4 times. It was a radiation patient, and I used the same propofol. I gave it at the same rate, and just completely heart stopped right after induction. For the most part, when an animal isn't doing well under anesthesia, they give you clues. I call them breadcrumbs. I'm like, follow the breadcrumbs. Respiratory rate had been dropping. Heart rate was dropping. Blood pressure was dropping. Jaw tone was getting loose. Eye position was central. Started throwing an arrhythmia. Color started looking off. Respiratory effort changed. You have to look at it all, and the more you're paying attention, and definitely speak up, because I've had students, and you know, you guys do this in class. I ask a question, I have 2 people answer me routinely, and nobody else says anything. And everybody's afraid because they don't want to sound stupid. They don't want to be wrong. And I get it. When you are in surgery, If you are concerned about something, you have to say something. Don't worry about being wrong. There's a chance you're wrong, but they are better light than dead. I'd rather err and you wake up the patient and they start moving. I've made the wrong call. I turned this dog off one time because I thought the ECG looked strange, and then he started moving, and then I had to re-knock him out. But you know what? If I would have turned him up and left him and there was a problem, he could have died. And my doctor was not mad at me. My doctor was like, no, thank you for doing something about it. Like, I'd rather you err on the side of we got to knock them back out. I've never had a doctor be mad at me. And so if you are concerned, you always have to trust your gut, and you will develop more of a gut over time. It takes time. I've unfortunately over my career sometimes have made mistakes, and I learned from that, but I always was paying attention. I've caught some animals that I think were about ready to crash because I was paying attention, and I've turned off the anesthetic, or I bolused fluids, or we reversed drugs. So communicate, speak up. Don't be afraid to say anything. And if anybody yells at you for saying something or makes you feel stupid, I don't care if I'm no longer at that school. Tell me about it, because that's not right. You should be able to say something and make an error. You're learning. You're in school. It's okay to be wrong. But you got to say something. You're the advocate for your patient. Your patient is anesthetized. They cannot speak. They cannot move. Well, they can't speak anyway, even if they were awake. But you know, you have someone's beloved pet under your hands, under your care. And I don't care if in school they belong to the shelter, or if it's Fifi, you know, this lady's beloved poodle. Whatever animal, it's up to you to pay attention. And I hear people talking about weekend plans and what they did. And don't be looking at your phone. You better bring a calculator to do your math. Okay? You want to just be paying attention. So, and just don't be afraid to say something. Don't be afraid to make a judgment. This is you learning. And then obviously equipment related errors. Where is my mouse? Sorry. Okay, so equipment related errors, you know, maybe you set it up wrong. Maybe, you know, a lot of people get the tubes backwards. Probably if your patient's having a hard time breathing during anesthesia, normally they shouldn't have trouble breathing during anesthesia. If they're intubated on a machine with 100% oxygen, it's rare to have breathing problems under anesthesia. So that would be something that is rare. Sorry, my thing is frozen. Let's see if some other things that I would be concerned about, that's on the second slide here. I may have to reboot because I completely don't have my mouse. Okay, I apologize. I don't know what's going on. Equipment failure, obviously, or carbon dioxide exhaustion. So your soda lime granules should be changed once a month, or if you notice they're purple, like half purple, because depending on the size of animal and the flow rate depends on how fast you use your CO2 granules. But if they're exhausted, then that animal can be rebreathing CO2. So you're going to, and if the more they rebreathe their CO2, the higher their CO2, they become hypercapnic. And then that can lead to what's called metabolic acidosis. So usually an animal has respiratory acidosis first, and it can progress to metabolic acidosis if we don't control the respiratory acidosis. So that's why we want to make sure that we're monitoring their CO2, make sure that we're not in that scenario. Your oxygen supply could fail. You could run out. Now remember, you guys are using the e-tanks that are attached to the machine. You should always have one that is in use and one that is full. If for some reason someone left an empty tank on, like they didn't change the tank, and the full one ran out, then in the middle of the procedure, you have no oxygen. So you always want to make sure, and at school, they really try to run those tanks to the lowest. It's like you driving to the gas tank or the gas station on fumes. You're on that E and you're like, I can make it. I can go 2 more miles. It's kind of, sometimes you'll look at your tank gauge and it'll be in the red section, which is empty. But if your flow meter is on, you have oxygen flow. So I always tell students, if you have a low tank, just keep an eye on your flow meter. If your flow meter starts to drop, if it's starting to drop and you have not turned the dial, it means your tank is running out of oxygen. And then you go ahead and switch. You turn the in-use off and you turn the backup tank on. And you can do that in the middle of a procedure. You can just switch tanks. You don't have to do anything. And then obviously an ET2 blockage. Now, I'm trying to get you guys to critically think. What do you think a patient would show if they had a blocked tube? How would I know? Because I can't see inside their tube. You can't see inside the tube. So how would I know there's a blockage? Like a mucus plug, a blood clot.
The bag wouldn't be moving with their respiration?
Exactly. So, if a big red flag for me is an animal is moving their chest and the bag isn't moving. So their bag movement isn't matching the animal. What do you think? How do you think you'd be breathing if you were choking? If you had something stuck in your throat, and would you be like?
They're going to be hyperventilating or doing the, I can't ever say what they actually are, but the big belly breaths where they.
Abdominal breathing, more effort. Yeah, you're like, so your abdominal breathing, more effort. So it's very rare for an animal to abdominal, it almost looks like an agonal. It's like a, yeah. So those are all, and then potentially a rapid spike in CO2 because they're not exhaling, because they're not breathing efficiently. So no, those are all good. There have been times in my career I've had to change the endotracheal tube in the middle of surgery. I've had to and you have to do it upside down. You can do it. It takes some practice, but I've had to pull the tube out and put a new tube in because they're in the middle of surgery. I can't flip the dog over. I have to kind of do it like that. But it's rare, but sometimes they have mucus back there that you have to, So yeah, if I don't have everything is frozen. Oh my gosh. Oh yeah, it's 8:40. Yeah, my screen's completely I thought it was only 8:30. I'm like, it's been 8:30 for 5 minutes. Apologize. So I know that I talked a lot about that, but that's some key things to kind of mentally think about is like, how would I deal with these scenarios? I'm going to stop here. I'm going to try, would they be hypoxic and get light? Potentially. Yep, Bethany, you might see also that if they can't get oxygen, your SpO2 is falling. And again, if they're not inhaling, you're probably going to see them get hypoxic and hypercapnic before you would see them get light, but it could all happen in that scenario. And that's why I always hang on to my extra induction agent, because usually you guys will have, and maybe Miss Redmond will hold on to it, not you guys, but usually you'll have leftover propofol. Many times we don't use it all. I always kind of have it with me in case I have to like knock them out because they get light or have to re-intubate. And you don't want to have to be running So again, I never usually throw out my leftover induction agent till the animal is extubated and recovered. Because that's, the patient used that drug, they kind of paid for it, they have it, why not hold on to it? So I'll stop here. Again, I'm going to try to convert this. Hopefully the fact that it's frozen, I can't end anything appropriately. I'm going to have to just do a reboot. So, and I'm sorry. My husband's got to look at this laptop because it's been giving me fits. So you have a good rest of your day. I'll be in touch. And again, there's no homework section for this. I've posted this PowerPoint and I'll talk more about next week, maybe tomorrow. And I'll get into those tests. So sorry the last one took so long. This one won't. I'm starting it this afternoon. So, all right. I'll see you guys. Bye. Doing a hard shutdown here. Thanks. Bye. Okay.